People already wrote some questions. I'm going to start with those. But if anybody wants to chime in afterwards, some of them have already been answered. But I'm going to start with a question from one of my patients, so I'm biased. Would it be best to ensure that doctors, specialists run a medical workup or test at time of first diagnosis for more than one autoimmune disease, or is progression from one disease to scleroderma the natural process of the disease? So when I teach my fellows, I tell them, do I have a drawing board? I'll show you what I show them. I do this, I do this, I do this, I do this. Scleroderma, lupus, Sjogren's, RA. So these are not circles that are separate. They're circles that intertwine. You could be here, which means you have a lot. You could be here. You can move from one circle to another. You can go in between circles. So you have to keep your mind as a doctor or as a rheumatologist open at all times. I see patients who are diagnosed with lupus, but when I start seeing them and I start following them for a little while, I start recognizing symptoms of other diseases. I have patients who came to me as scleroderma, and they told me, listen, you're giving me this drug for my scleroderma, but my joints are bothering me. They're swollen, they're painful. I'm like, nah, it's the skin around the joint. So I keep going at it, because I'm biased as well. After a while, I'm like, all right, well, you're complaining enough, let's see what's going on. She has rheumatoid plus scleroderma, so I have to bring a rheumatoid drug on top of the scleroderma drug. So these diseases are not single entities on their own. They're intertwined. So maybe we should have a connective tissue disease society in the middle. Anyhow, that's the spiel on that.
Here's another one.
What is your opinion on Botox injections to treat Raynaud's? My opinion is a good one. I don't know of our colleague right there.
But only a select few. It shouldn't be first line.
Okay. So, there you go. Domperidone for gastroparesis. If you can find it in the United States, it would be great. Canada, you can find it. It is probably our third line. We will start with Reglan, erythromycin, an antibiotic you can use as well for gastroparesis. You can then go to domperidone. You can find it. You just have to try to get it from somewhere else. We used to have Propulsid on the US market, but it came off the market because there was too many cardiac side effects. I think Propulsid may still be in use in Europe as well. Cisapride, right. Is there any evidence that scleroderma results in a person after they have had a surgery that leaves something foreign in their body? As a heart valve, cow heart valve. Again, we really don't know what really starts scleroderma. I'll turn it around. If you have an autoimmune illness and you're given a bioprosthetic valve, there's rare patients that their body will actually go and attack the bioprosthetic valve, so you already have the disease. So that being the cause of your disease, we don't know. We really don't know what initiates this disease. But if, let's say you are a lupus patient or a scleroderma patient and you need a valve, and if you get a bioprosthetic valve, there are rare patients that their immune system, which is again fighting themselves, will see this foreign substance, the cow valve, and go after it. So the body will go and attack. And that's called valvulitis. I've seen it with lupus patients. So sometimes we prefer mechanical valves if a valve is required with somebody with a connective tissue disease. So the answer to the question, I don't know. I don't think a valve, or at least from what I know, that the valve could cause a disease. But, you know, that's what we say today. You know, I keep an open mind all the time as we understand things better. Should coronary artery disease or the other cardiac problems, example AFib, be treated differently in people with scleroderma? Yes. So there's patients that can have MIs in scleroderma that they go and get a cardiac cath. The coronaries are beautiful. There's no blockage. So you could have a vessel that contracts like your Raynaud's, potentially gives you a MI or damage to the heart, and then when the cardiologist goes back in there and the caths, they don't see anything. AFib is important also to look at it a little bit different. So when somebody has AFib, forget if you have scleroderma or any other disease, they will first look to see if the coronaries are blocked.
Explain what AFib is.
Atrial fibrillation. So your heart is going irregular. Instead of but, it's going but. Was it good enough? Very good.
I guess you didn't duck the question.
I did not duck the question. But, so, now that can happen if you're having decreased blood flow to your heart. But if they do a cardiac cath and your coronaries are clean, then something else is causing it. In rare cases with scleroderma, the heart is a big muscle. You can have a fibrotic bundle somewhere in the muscle. So if somebody has AFib, and I'm seeing if there's a patient of mine that has this who's not here. So if you have AFib, you go atrial fibrillation, and you go to the cardiologist, and they do a cath, and the coronaries are clean. The next step would be to get an MRI of the heart to see if there is fibrotic bundles within the heart. Because if the fibrotic bundle is hitting the electrical system of the heart, or is touching the electrical system of the heart, could potentially lead you to get arrhythmias. So yes, you need to look a little bit different in patients with coronary artery disease and AFib who have scleroderma.
Doctor, are you still anticoagulant for the AFib?
Me? Not me. You go to church and you pray if I anticoagulate. So, or to the temple. So, no, if you have AFib, you have to be anticoagulated. It is a sensitive subject in scleroderma to anticoagulate patients because, as you know, watermelon stomach is a diagnosis that we worry about. It can be a silent diagnosis, meaning you don't have symptoms, and then somebody anticoagulates you, and all of a sudden your hemoglobin starts dropping. So if you have a lot of telangiectasias on your face, you're at higher risk to have watermelon stomach or AVMs or dilated vessels in your GI tract. So if somebody tries to anticoagulate you, then there's a potential risk. So it's a sensitive subject. But if you have AFib and we cannot bring the atrial fibrillation back to a normal sinus rhythm, and the heart is dilated, then they will anticoagulate you. Is diabetes involvement common, and why? The only thing I can see as a relation is between steroids and scleroderma, and we use low doses of steroids. But per se, diabetes and scleroderma as an association, we don't know that of being. Biomarkers, blood tests available yet. We really don't have. They're being researched. They're being looked at. We're not doing them. Did you talk to them?
I did. You might talk about the use of the autoantibody test as a biomarker.
Right. Autoantibody. But are they predictive of disease types? Yes. Disease outcomes? Maybe. Again, we have unique cases where we could still have a patient who looks limited, just to give you ideas, and have blood tests for diffuse, and then diffuse patient by the skin and limited antibodies. Again, it's not perfect. We're looking for biomarkers, though, that I think that we can follow better and understand the disease better. So I'm not sure. CellCept generic, okay. If the FDA approved it as generic, I'm going to say yes, it's okay. So, abatacept for rheumatoid arthritis, compatible with CellCept. Yes, abatacept is being looked at. Dr. Sandorfi has a study right now for abatacept being looked at for scleroderma. Yes?
I thought we talked about this stuff.
Oh, they asked me a question.
It's compatible with CellCept, mycophenolate, but in the trial you would not be able to be on both.
Compatible with CellCept. I'm sorry.
Yeah, you couldn't be on both.
All right. So, are you allowed to be on CellCept in your study?
I don't think so.
No.
Okay, so you're not allowed to be in the study if you're on CellCept,
You
right?
just have to stop it first.
Right. Nothing seems to help my dry skin. Could it possibly be because of some medication? Yes, but of course Dr. Lisa Pappas has told you otherwise also.
Yeah, so,
It's only for the video, sorry.
oh.
So speak.
So it could be a medication. However, typically in the setting of systemic sclerosis, it's not. But usually in clinic, we can go through all of your medications, see when they were started, see when the itch started, and kind of evaluate your skin and see really typically a drug doesn't cause dry skin, but can cause itch. So if you have dry skin, that's not caused by the medication.
Is there a correlation between pulmonary hypertension and high blood pressure? So these are two different systems. There's a system, the system that goes out of your heart and then back to your heart and then between the heart and the lung. There are different systems. You can have high pressures in one system and normal pressures in the other system. So they're not the same system. Which doctor should I see for my high blood pressure? Your primary care doctor. So, but things that are important, we prefer certain drugs as rheumatologists, and hopefully your primary care doctor would know. We prefer calcium channel blockers because they will help your blood pressure and also help your Raynaud. We prefer ACE inhibitors because they will help potentially if you ever develop sclerodermal renal crisis, and they can also help your blood pressure. We do not like beta blockers. If you have to take it because you have a cardiac condition, that's fine. But a beta blocker typically worsens your Raynaud. It will treat your hypertension, but will worsen your Raynaud. So,
You want to speak to the benefit of home blood pressure monitoring for early disease?
oh, there's a question from the audience. So it is very important. If you guys never heard this is very important. You should check your blood pressure at home. Very important. The most common cause of death in the past for scleroderma before the 80s was rapid onset of high blood pressure, and then a rapid to the point that within days, and then seizures, heart failure, and potential kidney failure. It is very important. We have medications to treat this. It is very important to check your blood pressures, and if you see a trend of your numbers going up, to report it to your rheumatologist, your primary care doctor. It is something that is very treatable, and we can prevent this. And it has stopped being the #1 cause of death since they realized ACE inhibitors works very well for this. They did a recent study, which I was part of, looking if ACE inhibitors can protect you from developing this, and they have not shown that benefit. So starting an ACE inhibitor to protect you from scleroderma renal crisis does not help you. But if you develop it and you start the medication, it does help. So it is very important. If you never heard that, and hopefully everybody in this room has at least once heard it, or maybe, us doctors, we talk a lot and we talk. We don't know. You probably don't even listen to half of what we say. And if you have an accent like me or Dr. Sandorfi, you probably don't understand anything we say.
As a follow-up to that question, what kind of frequency should you be monitoring your blood pressure?
I tell my patients a couple times a week. Most patients start and do it daily. They initially, when I tell them that, they're a little bit freaked out. They look at all the details. And when I tell them that some variability is normal, daily there's variability. In the morning, a little bit higher, a little bit lower towards the day, because hormones are being released in your body to wake you up, which are like epinephrine types, steroids, your own production of steroids from your own adrenals. So there's a little bit of higher level of blood pressure early on, and then as the day goes down, your blood pressure goes down a little bit. But within like a 10-20% variability, not a huge.
But really, more early in the course of disease. It's really the first couple of years where the risk is particularly
With
high.
diffuse.
With diffuse disease, yeah.
Right.
So don't go home all of a sudden like, oh my God. So.
Also on that, should you do it at a regular time of day, like in the evening or morning? Or
I would, right, because then you can have some comparison that is similar. More information about interstitial lung disease. What? So,
How do you spell it?
interstitial lung disease. So what, if it's more specific, what is it?
Well, it's the space between your lungs, is it in your chest?
It's actually inflammation within the lung tissue itself. It's part of scleroderma. Not everybody gets this, but what it does, there's inflammation early on in the disease in the lungs. If that happens to you, not everybody gets it. And then that inflammation leads to scar tissue. If we catch it early during the inflammation part of the process, we can actually intervene and do something to, so we do PFDs, we do breathing tests every year, which is what we're looking at. So if we start doing your breathing tests, they're normal. a year or two goes by, and then you're dropping the numbers. So something is happening. We do a CAT scan. We see inflammation in your lungs. We intervene at that moment because we try to take away the inflammation from your lungs so it doesn't go into scar tissue. Once you go to scar tissue, so there's also patients that come to me already have developed scar tissue. And I do a breathing test here, and then I have 4 months later, and the breathing test is the same. So the war happened back there somewhere, the battle is over, and now I'm seeing the casualties. There's nothing I can do. I mean, I can give you medications, but they're not going to do too much at that point. So that's why it depends where you are. If you're on a downward trend with your breathing test, and there's a lot of inflammation in your lungs, we can intervene. If the scar tissue has formed, and there's no more inflammation there, the intervention is not going to help you that much. So, I mean, that's part of it. How will stem cells help a person with PAH? I don't know the answer to that. Do you know that answer?
What was that?
How do stem cells
and
help PAH?
Well, I think we don't exactly know how stem cell transplant does anything. The stem cell transplant, it's not the stem cells so much as the treatment. It's the high-dose chemotherapy that wipes out some of the cells. Stem cells more the rescue. It's the treatment for the treatment to some extent. It may also have benefits. And what we're thinking is you get rid of the bad cells, it stops the ongoing disease activity. If there's disease in the lungs that's reversible and it can heal itself, it gives itself a chance to do that. So someone asked me earlier, my wife's on a therapy. I'm not sure her lungs are getting better. But I said, are they getting worse? And sometimes our treatment's designed, we'd love to have things get better, but sometimes what we're trying to do is actually make things not get worse. And that can actually be good if you're already not too bad off. And so some things we do will hopefully our treatments will either stabilize or make things better. The transplant idea is let the body heal itself and let it stop from getting worse. Because there are some natural improvements in scleroderma. Many people's skin gets better after the first 18, 24, 36 months, a couple of years. Lungs tend not to heal on their own, but sometimes they stabilize on their own, certainly, and they sometimes get better. So we're not exactly sure because we haven't seen a super drug. I think we all hope to see a super drug that reverses everything.
So what do we know about stem cells? Like Peter said, it's improvement of skin, stability of the internal organs. Not improvement, stability.
I have a follow-up question on stem cells. It's a two-part question. First is, how long can you store the harvested cells and have them remain viable? And the second part is a follow-up to that. If you're early in the disease stage, is it worthwhile to have your cells harvested where I presume you have a lot more healthy cells than, say, a later stage of the harvest?
I'm going to defer over here.
I got
So
stuck with the first one
storing
because
stem
I'm thinking
cells.
about it.
How long will harvested cells last in the frozen state?
If you freeze them, they can last forever.
Yeah, I mean, unless your system does.
It's the home market with the umbilical cord, right? You have a child, they take this step.
Yeah.
So, I mean, that's a huge
I
market.
mean,
in the
I'm
United
sure that
States.
there is probably some very slow death to those cells as well. I mean, the frozen cells. I mean, probably there's some % of those cells die off during the storage. But the freezing process itself is like, sperm cells being frozen, eggs being frozen.
From that standpoint, then, if you're early in the disease stages and you're early in diagnosis, would it be worthwhile having that done?
Dr. Mercaz?
I'm not sure that's necessarily a great idea. It's not that your cells are so bad that are attacking you. As a matter of fact, early in disease, they may be worse. So it's really the harvesting of the stem cells is a very complicated process. It's easy for you. You sit there, they take it out, your blood, it goes into a machine. But then all sorts of amazing things are done and sorting and doing stuff. So I'd be careful about sort of doing some of that ahead of time. It's sort of interesting. You could argue, should everybody, scleroderma or not, have some stem cells stored? I'm not sure we have enough money in this country to do that for everybody, but I'm not sure for scleroderma we're anywhere near at that point. It's an interesting concept, but.
Dr. Merkel, if I can add in here, I have direct communication with a patient who went through this process in California, and it's not really about the freezing of the cells, it's about keeping the patient because they're susceptible at that point where they harvest this material to whatever comes their way. So it's about keeping them disease-free until such time they can.
It's when
That's allogeneic.
it's
No. So remember the picture I had up? Person, they take the cells, and the whole process happens, okay? And then they freeze the cells. Then comes the actual chemotherapy with the radiation, with the whatever other factors, and then the cells are being given back. So after harvestation or harvesting, it is strenuous to the patient because they undergo different kind of, they give a lot of fluid and whatever happens.
well, they
I
wipe
don't
out your
remember
immune
exactly.
system. Your immune system is wiped out.
Afterwards.
Right. So but you're
The
wiped
actual
out.
collection of the cells is not a
Right,
problem.
but it's the period of time when your immune system is wiped out. You're in a hospital in what is called a lockdown unit, protected from infections. That's the risky period. That could be a month, that could be a couple of weeks. Usually it's a month. It takes a while. And then those stem cells have to take. And when they take, then you start building immune. It's your own stem cells. So are they young enough to not have understood your disease? There's a lot of questions still. So is an allogeneic transplant from somebody else a better transplant? There's also more risk by that. I mean, right now, most of the transplants are autologous transplants for this disease. So we're not there. We don't have the answers to those questions, I think, right now. I wouldn't go running for stem cell transplants. That's what I would say. All right. Finger and toenail care. I think you covered it very well. Why are allergies worse with scleroderma? I'm not sure if that's a true statement or not. Why do you get like a keloid on your face? Do I need to see a dermatologist? Correct. A keloid is an overabundance of fibrotic tissue. You do not have to have scleroderma to develop a keloid. Typically more commonly seen in our African American patients. There are ways you can treat it, and Dr. Pappas can tell you. From what I understand, I think they inject steroids, and that kind of shrinks the keloid, but it's an overgrowth of collagen. Can you explain the importance of physical therapy? I think it's very important to go through physical therapy. Nothing will get harmed. I think, especially if this is only the skin, there's no significant joint involvement, and I tell my patients that they can push it themselves to the limit. Also, heating collagen. Collagen is twisted in a triple helix, and it has the sulfide bonds that connect it. Those bonds can actually loosen up if you massage the area or heat up the area. So a lot of my patients take warm baths in the morning. So the bath actually helps loosen things up. Once the cold weather hits them, though, and again, there was a very nice technique that Dr. Papa said. Don't dry yourself up. Put some lubricating grease up and stuff like that to keep the moisture. But yes, massaging the area will soften up skin. We actually, when I was at Jefferson, we actually did this study where we brought a patient in. We were looking at an ultrasound machine to look at thickness of skin. We put the ultrasound machine to see how thick the skin was, and it gave us a number. And all we did, we just massaged the area. And then we put that probe later on again. It looked less thick. We waited a little bit later. The things went back. Again, we didn't do the study, but they wanted us to look at this probe to see if we were able to do a study. We didn't think we could do a study. But we just did this little experiment on one patient, and the skin thickness was thicker again after we let this. So yes, massaging the skin can help loosen things up, but for a short period of time. Current locations doing stem cell transplants, the SCOT trial. I was part of the SCOT trial at Jefferson. I was not able to recruit one patient. So I closed it when I was at Jefferson because nobody was really interested in the study. At that point, we had the study open maybe 3 years, I think, at Jefferson. We didn't have a single patient interested. It is significant. It's a significant study. There are other centers that are still doing it. You can go to clinicaltrials.gov and you can put SCOT trial. It will tell you where. Is it? Is it?
We did a couple of patients in Boston before I left.
Right. So it's hard to recruit. stem cell transplant process, how long does it take? Well, there's the process that is the longest is the period of time when you don't have an immune system. That's the biggest process. The harvesting, the radiation, whatever they give you to wipe out your immune system can happen pretty fast. I would say maybe a couple of months, the whole process. But the biggest part is that time period that you're waiting for your stem cells that you have now been transplanted to kind of take over into the bone marrow and give you this new immune system. And that's the period of time that you're more susceptible to infections. Who are the UPenn gastro doctors involved in the scleroderma program? Somebody talked about the gastro doctors?
Someone might have.
All right. Then answer the question.
So we have, it depends on, I don't want to start referring to individual physicians in this setting, but we have people particularly for upper digestive tract, so esophagus and swallowing. We have a couple of people, Dave Metz, a couple other folks, and then sort of if there's a lower problem. We have different people for different issues. That's how specialized they are. And there's also actually a very nice nurse practitioner who does intake and then try to figure out who the patient goes to, because often we get some testing beforehand. The doctor makes some comments. So I think it really depends on the situation and who it is, and then if there's urgent issues, the whole team sort of deals with it if there's bleeding or other issues. So it's all within the context of what you have.
If you have diastolic dysfunction, can you be in the Labratory study? No. It's because there's a risk that if that person that has diastolic dysfunction, they have heart failure, and if you give Labratories, you can potentially worsen the heart failure. Will a strict juicing diet for 90 days or longer help cure scleroderma? Who wrote that? Who wrote that? Come on. Somebody stand up and tell me I'm sorry, whoever did it.
Don't squeeze it out.
No, I'm not going to squeeze it out. So I wish it did. I wish it did. Whoever wrote it, with all seriousness, I wish it did. I wish it helped. I don't want to put anybody's ideas down. I tell my patients, as long as I've had patients that have done all kinds of things, I'm open to it. I just want to hear about it. I've had people that they did weird, unusual agents that didn't even know. I had to go research them myself. They went to homeopaths. So I understand that this is happening. I know you're doing it. I know you're not taking all of the medications I'm giving you. I know you're going and finding somebody who promises that if they take your blood out and wash it out and give it back to you, they might treat your disease. I understand it. You're looking for things to cure you. I understand what's happening. I'm open. I will listen. I will search it. I will tell you, listen, you're going a little bit too far. You're doing it a little bit too crazy. I will tell you that. You may want to listen to me. You may not want to listen to me. You pay me to tell you what I think. If you don't want to take it, you don't take it. But again, they can sell a lot of products. They can make a lot of money. I don't know. If anything helps, I'm all for it as long as it does not harm you. That's how I answer that question. Is laser treatment safe for correcting sun damage in scleroderma patients?
So it depends on what laser. So some lasers have been looked at more in connective tissue diseases. I could always help you with a specific laser, but some of them have not been looked at. So that it would have to be a long answer. Sorry.
All right. Please discuss stem cell transplants for scleroderma and amyloidosis. I have both. Can you recommend a doctor? I can recommend Dr. Merkel's wife, who is an amyloidosis specialist. There you go.
So actually, amyloidosis is another very difficult and rare disease. If you have amyloidosis because of scleroderma, that may be one form of amyloidosis, but there's actually quite a few forms. So I don't know who this is, and it's not the right time or place, but it would be if you truly have amyloidosis, you should be seen at a major amyloid program. It's a very unusual and disease, so Penn has a nice amyloid program as well. Patients with untreated inflammatory diseases can get one form of amyloidosis, but you can also get it from genetics, and you can also get it in other ways. So it's complicated. It could be from the scleroderma, but also, unfortunately, as I say to people, just because you have scleroderma, unfortunately, doesn't mean you're not allowed to get something else, which doesn't seem fair. But you still have to look both ways when you cross the street, and you can still get a cold from your grandkid. So you're still going to get stuff.
All right. Any other question?
It was said that the single lung transplant is as effective as the double. Do you ever take lung transplants from living donors since you can just do one?
They've done it?
There are living donors for lung. Usually it's a lobe. It's maybe sometimes one of the bigger lobes. You don't need that much lung to function, actually, to function pretty well. You're not going to necessarily win the marathon. But that has been done. There are living donors for lungs. It's not so simple. But it is being done at some centers. It's not quite as easy as living-related kidney donor because you have that. So transplant medicine is changing constantly and for the better. So it is interesting.
I have a question. I want to know, is there any, or have there been any studies done to evaluate someone's environment, their living conditions, to find out that, I know we don't know what causes scleroderma and all these other things, but if removing a person from that environment while they're still getting treatment has any marked improvement, or is it just something, like you said, that's just genetic and you're bound to get it anyway?
Right, so I mean, there's epidemiological studies that have shown some links, but those links are just based on epidemiological studies. And people that work in plastics industry, people that work in silica mines, people that work in the petrochemical industry or have any relation to, again, these are things that are interesting. We've seen it, we've observed it. Studies have been published about it. You cannot, like the study with silicone breast implants back in the 80s. There was one study that showed some abnormalities, then they did a bigger meta-analysis, and that meta-analysis suggested no, maybe it's not. But still, something in the back of your mind. I ask those questions when I see patients. It's interesting, I record it down on my chart, but I don't know if, now, once the immune system has clicked and decided to go a little bit crazy on us, and it's attacking our own body, at that point, I don't know if it makes any difference, because the switch has been turned on. You have a switch in your body, and if you're lucky, you might go your whole life and nobody turns that switch on. What turns the switch on? Is it a chemical? Is it a virus? Is it, I don't know, an injury? We don't know what turns it. We just know you have a switch, and that switch turns on. There's people that probably live all their life with risk for scleroderma and never develop it because that switch doesn't get turned on.
I think we're going to...
Can I get a big hand for Dr. Derk?